Thank you very much, sir. Do's and don'ts of vitreous surgery. We have finished incisions and minimally invasive scleral buckling. So the objectives would be to show some common steps in vitrectomy, and there are different indications in which we will do different steps and the special steps. So it could not be shown as a single video. So machine-related information we should always have. What is the power of our machine? What is our microscope, X, Y, zoom? That is something cryo, PFCL, everything is working or not, we have to find out before we start the surgery. Because halfway through the surgery, it is very difficult, or you require a cryo, and cryo is not in US and it becomes very difficult. So you should have that information. What is an ideal case for a beginner? An aphakic patient or a clear cornea, adequate pupillary dilatation, PVD is complete, and there is no retinal detachment. This would be an ideal case for a beginner. And more complex cases, yes, endophthalmitis, PVR, PDR, ROP, ocular trauma, these are more complicated cases. So for the guidelines, there are certain basic things that we have to look at for each of the vitreous surgery. The infusion cannula has to be the first in and to be the last out. That maintains the pressure of the globe while we are doing the surgery, and that should be there. Cutting, never, when you're cutting, don't cut while you're moving away. Generally cut when you are coming in or always near that area. If you cut and pull, maybe there is a chance of a retinal tear occurring. Suction should be reduced when you go close to the retina, and entry towards, always direct towards the center of the globe, and always keep away from the clear lens, and always learn to decide when to stop. That is a very important thing. I will not go into wound construction. Now setting up the infusion. Placing of the cannula is an important thing. Like usually in a phakic we will keep it about 4 millimeters, and in a pseudophakic at 3.5 and a phakic at about 3. This is the difference between a 20 gauge and a 25 gauge cannula placement. There are different things which will decide on if it is a pediatric, very neonatal age group, we may come very closer to the limbus. If there is a choroidal detachment there, we may create a straighter entry. So you may use a 6 millimeter infusion cannula for that purpose rather than a 4 millimeter infusion cannula. But the crux is you should always visualize a tip in the vitreous cavity. When to switch on the infusion? So maybe you can make all the remaining ports and then have the infusion cannula visualized inside, and then only start the infusion. Because otherwise, if the infusion runs down below the retina or in the suprachoroidal space, you are into more trouble. If the gel herniates through an opening, which is very uncommon in a 23 or a 25 gauge surgery, which is more common in a 20 gauge surgery, don't push it down, cut it out. Cleaning the vitreous, first we will do a core vitrectomy and move to the region within where the PVD is complete and maximum. Ultrasound is generally helpful, preoperative ultrasound is generally helpful in this respect, and identify the edge of the detached hyaloid and work from there, and try to raise the hyaloid from that particular area and then work along this separation and keep away from the lens and also the retina. So that is a PVD induction. This we are using a green tip for this. You can see the fish strike sign. So this is a time when we did not use, this is very old, probably 10 or 15-year-old video, where we are not using a stain to, stain for the vitreous. Now, but we are using a triamcinolone like this, so that you can very easily visualize the vitreous and hold on to an edge of vitreous all around the disc, and then you can see a see the how does this work? How does this pointer work? Yeah. So next is you may require to actually use scissors to remove the hyaloid in certain particular areas. You may use a cutter very close or okay. Epiretinal membrane is another. Now we will go to some special situations. For an epiretinal membrane or a macular surgery, you do not require to go right to the periphery for a vitrectomy. Probably you could go beyond the equator. And then I am using a triamcinolone stain first to identify that epiretinal membrane which is getting removed. But the edge of this we have to visualize always to see that there is no tear or anything occurring there. So once this was the end of a epiretinal membrane, but generally at the end of epiretinal membrane surgery, you should again stain with brilliant blue green and remove the ILM. This is again another epiretinal membrane which the sheet is very well formed, so that is very easily separable. This was taut hyaloid in a diabetic patient. So this is being removed easily like that. Okay. Next, coming to, but at the end of surgery, we have to make sure that we intent and see that there is no peripheral pathology. If there is a peripheral pathology, it is always better to treat it pre-operatively itself, because PVD induction many a time can cause a problem in such situations. Now this is again a ILM peeling in a macular hole. You can see the macular hole in the center. So after the core vitrectomy is over, after the PVD is induced, after you go and remove the PVD till the beyond the equator, then you probably, now this is a triamcinolone stain, and this is the ILM which we try to remove all around, and you can do it in a circular fashion. But more easier now with a brilliant blue-green stain. Now you can see the excellent visualization. This is an initial separation of the ILM which was created by a pinch and peel technique, and now you can see the excellent contrast of this ILM with the rest of the non-stained retina, and you generally try to remove the ILM on top of the hole, across the hole, so that all the traction on the hole is removed. Actually you can see that it is done that like that. If it is a very large hole, generally we may consider doing a inverted peel technique. Now in a nucleus drop, generally you have to disengage all the vitreous onto the edge of the nucleus, and I generally do not perform a complete PVD before phacofragmentation, basically because that cushion of vitreous will always remain when I am doing a phacofragmentation. And you can use your frag, the cutter and the suction, the phaco power has to be dependent on the hardness of the nucleus, and based on that we will basically do that. And at the end of the phacofragmentation, we will complete it with a PVD induction and complete vitrectomy. PDR with vitreous hemorrhage, if there is a separation of the hyaloid, if there is a PVD, then it is easy. You could stay in this plane and raise the hyaloid and then look at the edge of the retina. But after sometimes during a subhyaloid hemorrhage like this, after you finish the after you cut off this hyaloid and remove the subhyaloid blood, you may see that this traction is remaining here, and now we will require to use segmentation or delamination techniques using scissors, vertical scissors or curved scissors. But nowadays with smaller instrumentation, 25 gauge vitrectomy, you can insuinate the 25 gauge vitrectomy probe below the traction membrane and take it out. Sub-ILM bleed, you may require to remove the ILM on top of the blood so that you can remove the blood simply. TRD at the macula, this is a dense TRD which we are trying to tease up with you can use a tissue manipulator or a bent 26 gauge 1 inch needle, but the basic idea is to remove that and then segment it into multiple pieces. Like this traction is running, so basically we will try to segment it into smaller pieces and then further into smaller pieces and then try to completely remove it. So this is again PDR with secondary rhegmatogenous RD. You have to completely remove. You can see the buccal indent here, so I had put a buccal there and do a fluid exchange first, so that and then only we will consider the next step. Now coming on to more severe traction, you may require bimanual procedures like this. So you have, on one hand you are using a forceps, and on the other hand you are using a scissors or a probe to remove the traction. So bimanual surgery is required. In retinal detachment, it is always important that you go near the tear. This is the tear. Identify the tear and do a vitrectomy complete all around the tear and remove the whole vitreous. Now in a retinal detachment surgery, I think Saravanan would be going into that. Okay. So in a mobile retina, basically you should remove all the traction. Finally, we will end up the surgery, even if it is a PDR or a retinal detachment with a laser and then maybe a tamponade. So laser should be done, it should not be very close. You may damage the retina, you may char the retina, you may have a burst or a tear in the retina, and it should be adequately lasered till the periphery. And during laser also, we should know that you should not go beyond the extreme periphery so that lens touch or something can occur. Finally, you finish with silicone oil injection or tamponade. I think Darius will be dealing with tamponade. To conclude, for success in vitreous surgery, we should mentally plan each surgery. We should know what are the problems. We should and we should plan what are the steps I am going to take, and look at the machine, look at the machinery, look at the visualization. Each step is very important. Any step, if there is a problem, you can completely, it is not like other surgeries. If you have a problem in one step and if you do not tackle it properly, you lose the vision in that patient. Intraoperative decision making and changes in decision making are important. Intraoperative complication management is also important. Strong hand, strong mind and good hands, best seriopsis. You will do a good job. Thank you very much.